For thousands of years, it has been the traditional land of the Huron-Wendat, the Petun First Nations, and the Seneca, and most recently, the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island. Sick Kids is committed to working towards new relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land in caring for children and their families. Today, it's my distinct pleasure, next slide, please, to introduce our speaker, Dr. Sanjay Mahant, for professorial rounds. He'll be speaking on hospital medicine, the practice, the science, and the future. Sanjay graduated from the University of Toronto and did the majority of his training here at U of T and Sick Kids. He also completed a master's in health research methodology at McMaster University. Sanjay holds many roles here at the hospital, both in the clinical world as well as in research. He's a hospitalist and clinician investigator whose research is really aimed at generating outcomes evidence to improve the healthcare delivery to hospitalized patients. He has three main focus of research, which he'll, I think, discuss today, including the effectiveness of clinical strategies, shared decision-making and patient perspectives, and an evaluation of the performance of our health systems. He has more than 80 publications in high-impact journals, including JAMA Pediatrics. He is also the senior deputy editor of the Journal of Hospital Medicine and has received multiple awards, including the Harry Bain Award twice, the William Feldman Peds Research Excellence Award, and the Richard Rowe Clinical Excellence Award. And most recently, I'm very grateful that he's accepted the role as the chair of the Department of the Pediatrics Awards Nomination Committee. So it's with great pleasure that I introduce Dr. Sanjay Mahant for today's professorial rounds. Welcome, Sanjay.
Thanks, Meredith. Can you see my slides?
Yes, we can see your slide.
Yep.
Perfect, okay. Great, okay, so thanks, Meredith. It's really an honor for me to speak today at Grand Rounds today at the institution where I trained and practiced my entire career as a generalist in hospital medicine. And it's been a tough year, I think, for everyone, and the pandemic has made me really think about what's important at work and in life. And it's a real privilege today to be able to be in a position to share my reflections on hospital medicine and what I think is important as well. So I'll get started right now. So it was 1999 when I finished pediatric residency at Sick Kids, and I remember landing and was really excited about the job that I was hired into on a relatively new pediatric hospital medicine unit. And it was a time when Dr. Patricia Parkin was the division chief. And I just want to check if you can see me, Steve.
Yeah, we can see you.
Yeah, sure, perfect, okay. So Dr. Patricia Parkin was a division chief, and the original hospitalists were Dr. Jeremy Friedman, Dr. Stacy Bernstein, and Dr. Michael Peer. And then came Dr. Michael Weinstein, Beth Gamulka, Tara Barron, who's now in Sudbury, and then myself. And at this time, hospital medicine was actually just in its infancy, and the term hospitalist had just been coined 3 years prior in 1996 by Dr. Robert Wachter at UCSF. So hospital medicine is a branch of internal medicine in pediatrics. And rather than being organized around an organ or a disease, it's organized around the location of care, the inpatient unit. So similar to critical care medicine and emergency medicine, with hospital medicine being the youngest of all the generalist specialties or subspecialties. And so I remember when I was a resident, I was really inspired by my hospital medicine attendings, who I think were the epitome of generalism. I remember in my first year of residency, in my first rotation, the late Dr. Norm Saunders taught me the importance of communication, trust, and being there for the journey with families of children with medical complexity. Then I remember later in my training, Dr. Patricia Parkin, she really consolidated my understanding of generalism, the social determinants of health, and introduced me to the concept of outcomes research, which had been the vision of Dr. Bill Feldman, who created our division's pediatric outcomes research team. And then I remember in my fourth year, Drs. Friedman and Bernstein took me on for 5 months as an apprentice on the hospice unit, teaching me the art of clinical medicine. So how to use the history and physical exam to practice in an elegant style of clinical medicine in contrast to test-based medicine. So then what is generalism and the generalist approach? I think it's one that keeps, that values broad knowledge and open stance, focusing on all the particulars, but keeping the whole in view, whether it's the whole child or whether it's the whole family, connecting and integrating across body parts and organs, across encounters, across relationships, putting it all together. And all my mentors, I think, were really grounded in real world practice and relationships. So whether it was clinical practice, advocacy, research, or education. And I remember really being exciting to be working as a generalist in this team-based environment. I loved working within a team with skilled colleagues, trainees, and allied health professionals. And I remember from the unit clerk to the housekeeping staff to the bedside nurses, they were all really integral to the care of the child and the family. And it was, and it still really is a privilege for me to be the attending of record for children and work with their families during this really stressful period in their lives. And still to this day, I find that every day on the inpatient unit is a challenge. It's exciting, it's fast paced, but it's also really stressful. And every morning, I think when I walk down this hallway, I always wonder what challenge is going to be waiting for me. The breadth of clinical medicine really is incredible in terms of the child and family context, the type of conditions, whether it's a common or rare disease, whether it's an acute or chronic disease, whether it's a predictable or unpredictable trajectory, low and high illness severity, physical and mental health, well-differentiated and undifferentiated presentations, single system and multi-system disease, medical and psychosocial complexity, from the neonate to the adolescent, from birth to end of life, and much more. I remember as I worked the weeks, the months, and the years on the inpatient unit, many questions came up about my practice, the practice of others, and how we were delivering care. And these questions, in one way or another, dealt with this fundamental question of how can we do better? How can we advance as a young field and improve the healthcare delivery and outcomes for hospitalized children? So for my talk today, I'm going to focus on three perspectives on this issue. First is from the perspective of the individual clinician and reflect on the pursuit to being a better clinician. And second is from the perspective of our field of hospital medicine. And I'll talk a bit about the scientific knowledge that's needed to improve outcomes and care, outcomes research, which is my research focus. And I'll use some examples of studies that I've conducted. And then third, I'll end off with some thoughts on future opportunities and challenges in hospital medicine. And I think when I reflect on my career and what I've learned, I think if there's one message that I want to share with you today, and I hope that you take home from my talk, it's a realization of the importance of humility for clinical practice, academic work, and leadership. Humility is a rich, multidimensional construct. It's a strength and should not be considered a weakness. An ounce of humility is worth more than a ton of arrogance. So now to the first part of my talk. So individual clinical practice on the inpatient unit. So clinical work and caring for patients and developing clinical expertise is hard work and it's a life's work. So how do we get better? So as attending on a generalist service, I've had the privilege of working and learning from so many different types of clinicians. And there were always these outlier clinicians, these positive deviants. I'd always cherished seeing them walking down the hall to help with a difficult case. And I always wondered, how do they do it? And I remember early in my career, I was inspired by Daniel Goldman's work on what makes an excellent leader and thought, why can't we study excellent clinicians in a similar way? So then Dr. Anu Wagwa, my wife, and I conducted a qualitative study using a grounded theory approach of peer-nominated excellent clinicians in the department. So we interviewed and studied a group of 13 clinicians in the department. Over half of them were female and included generalists, specialists of all job activity profiles. So what did we find? We found that at the core, these clinicians were driven by high intrinsic motivation for patient care and humility. They engage in specific types of practices, reflective practice and scholarship to achieve high performance in the real world. And by intrinsic motivation, I'm referring to motivation that comes from within the individual, also referred by them as drive or passion for patient care. So this is in contrast to extrinsic motivation, which is often driven by external rewards. As this clinician stated, you have to put passion first. Your patients have to come first. The well-being of your patients and the care you give has to be first and foremost. And I think this is a timeless concept. Dr. Francis Peabody in 1927, in a speech to Harvard medical students, said, "One of the essential qualities in the clinician is an interest in humanity, for the secret of the care of the patient is in caring for the patient." So I really wanted to focus today on this concept of humility that emerged as central to the theory of the excellent clinician. Interview after interview, it kept on coming up. And initially this was surprising because if you think about our culture where individual success, so focusing on yourself, is so valued and rewarded. Humility, if you think about it, it's rarely positioned prominently in any of our academic institutional values, or even for that fact, even in medical education training. Think about the hidden curriculum and what trainees and faculty probably actually learn. But this is in contrast to what these excellent clinicians were saying. For example, there's no place for arrogance in clinical care. The person who thinks they know it all, you're dangerous. It's time for you to retire. There's always something we can learn, and there isn't a week that goes by in this institution that I don't. Traditional definitions position humility negatively, the quality of having a modest or low view of one's importance. But what we found was much different. It was a positive attribute, a strength. So what did humility look like? Why was it important? Let's hear from these excellent clinicians. First, it meant having insight into one's abilities and limits. You have to know what you don't know. It's not necessarily just about knowing everything, but about how you use those gaps in knowledge so that you seek out the answers. It meant understanding the limits of medical knowledge and science. As you get older, you realize the stuff you thought you knew, you didn't really know it, or what you learned 20 years ago has all been changed now. Think about what the pandemic has taught us about knowledge, the limits of knowledge and science, and what it means to be an expert. Humility also meant having self-confidence. I think you've got to be able to have enough confidence to say, listen, I don't know that and I have to look it up. I have to go to somebody else. Humility meant recognizing one's position in the larger system. You can't be good unless you recognize that you're never going to have all the answers. You might be wrong. There isn't one way of doing things, that there are other people in this system that are going to have the answers. Humility also meant an openness to others. There are hierarchies in medicine, and I think some awareness of that is critical. People who break down the hierarchies, who allow for people to overcome those barriers, allow for a more open discussion, to listen properly to someone's opinion, and make for a better clinician. It also meant valuing patients' experience. We don't have all the science yet. Now, patients can teach us a lot too. And it comes back to an open mind. If we completely overassume that we know everything, there's no way we'll be flexible to realizing that we don't know everything. I think it's quite amazing to see patients over the years, and they still teach you a lot. You learn how they've dealt with the disease, even how the disease has changed. So these concepts underlying humility in medical practice fell into two major dimensions: an inward or intellectual perspective and an outward or social perspective. In psychology, humility has been conceptualized as low self-focus and high other focus. Others have also noted the importance of humility in clinical practice. Dr. Maria Milopoulos studied expert diagnosticians and found that a skeptical stance toward their own knowledge and need for humility was critical. Atul Gawande, the surgeon from Boston, in his book, The Checklist Manifesto, described 3 secret ingredients for clinical excellence: discipline, teamwork, and humility. So then to summarize, humility is a rich, multidimensional construct, a strength that can calibrate how we as clinicians see our abilities, our limits, the limits of science, and the importance of others, and positively influences our clinical practice. And when combined with an intrinsic motivation for the care of our patients, these two forces are critical in driving us to improve and to be better. So humility is not only important for clinical practice, but it's also important for science and for improvement. For example, understanding and recognizing the limits of knowledge and science opens our minds to being curious, challenging dogma, thinking about and being open to new ideas and theories and new solutions. Valuing the patient's perspective in health and illness encourages us to prioritize the patient and population goals in our scientific work and improvement. And recognizing one's position and the larger system opens our mind to studying the system and thinking about how the system can be improved so that all individuals and the population achieve the best outcomes. And all of these perspectives are central to outcomes research, which is my focus in hospital medicine. But before I delve into outcomes research, I just wanted to acknowledge that we need a breadth of scientific knowledge, from basic science to implementation science and quality improvement and patient safety, really to improve care and outcomes in hospital medicine. So what is outcomes research? Outcomes research answers this fundamental question of what is being achieved for patients and what can be done better. Its focus is on outcomes that patients experience in real-world settings. So outcomes research grew in the 90s out of a need to provide more meaningful scientific evidence to aid decisions made by all who participate in healthcare. So traditionally, research outcomes would often be focused only on physiologic measures or diagnostic test results, outcomes that many times just weren't meaningful enough for patients and clinicians to make decisions. Or they were surrogate measures that were really not helpful in knowing the true outcome that patients experience. Furthermore, research often did not incorporate patient values and preferences, nor did it evaluate how the healthcare system was functioning for a population of patients. So the goal of outcomes research is to generate knowledge to improve decisions and healthcare policies for application to practice to improve patient outcomes. So the three domains of outcomes research include comparative effectiveness research, so what clinical strategies work in real-world settings, the perspective of the patient, so the generation of knowledge that aligns patient care decisions with patient preferences, and then systems performance, so optimally implementing strategies that work to prevent, diagnose, and treat disease, eliminate waste, and ensure equity and return on investment. And it uses diverse methods from clinical epidemiology, informatics, statistics, social sciences, and also implementation science. And I'm going to take you through the domains of outcomes research by sharing examples of my work in each of these domains. So for comparative effectiveness, the management of a common inpatient condition, bronchiolitis. Patient perspective, I'll talk about shared decision-making in children with medical complexity. And for health systems and performance, I'll talk about the quality of perioperative care for one of the most common surgeries performed in children, tonsillectomy. So determining which strategies work in the real world, whether it's drugs, vaccines, supportive care, or a model of care, is what comparative effectiveness research is focused on. So in pediatrics, we face many gaps in knowledge that lead to uncertainty in decision-making. Dr. A.L. Cohen's group has shown that there's been this real stagnant growth or no growth in pediatric randomized controlled trials published in major medical journals over the past 15 years when you compare that to adult medicine. This uncertainty leads to practice variation. This figure displays hospitals on the x-axis, and on the y-axis is the percentage of patients at a hospital that are receiving a particular intervention. And this could be heated high flow for bronchiolitis. It could be early transition to oral antibiotics for common infections. You can switch this for anything, and I bet you the figure would be same in hospital medicine. If we knew what intervention was effective through comparative effectiveness research, then we could reduce this unnecessary variation and improve outcomes. And by improving outcomes, I'm referring to not only improving clinical outcomes such as time to recovery, but also outcomes related to reducing unnecessary tests and treatments, which reduces waste and harms of ineffective interventions. So examples of practice-changing comparative effectiveness research include the landmark penicillin prophylaxis trial for reducing infection in children with sickle cell disease, or the ED multicenter bronchiolitis steroid trial that showed that it was ineffective in reducing admission rates, but also later outcomes. So equally are important are trials that tell us what works but also trials that tell us what doesn't work. So research networks, I think, are essential to producing generalizable comparative effectiveness research efficiently. Think about the ways that networks in emergency medicine, ICU, oncology have transformed the field and practice. In 2009, I was invited to work with 7 other hospitalist researchers in the US to redesign their national pediatric hospital medicine national research network called PRIZE, which represents over 100 US hospitals. And practice-changing research from the network includes, for example, the development of a resident handoff bundle program to improve patient safety. So this study, which included sick kids and was led by Doctors Coffey and Bismillah, showed that the IPASS program was associated with reduced medical errors. And then generating evidence around clinical management, such as the comparative effectiveness of IV versus oral antibiotics for post-discharge treatment of acute osteomyelitis, which showed that early transition to oral antibiotics was as effective but safer than longer IV treatment through a PICC line. However, for a variety of reasons, we need our own Canadian inpatient research network. And then in 2019, Dr. Peter Gill, myself, and with the wisdom of Dr. Patricia Parkin and colleagues across Canada, formed PERN, the Pediatric Inpatient Research Network, which includes almost all the major academic centers across the country and major community hospitals. And our goal here is really to generate evidence to improve care and outcomes for hospitalized children in general pediatric settings, to facilitate knowledge translation, and also to build research capacity through mentorship and collaboration. And I think patient partnership is important, and Dr. Gill is leading a CHR-funded priority setting study to determine the top unanswered questions in pediatric hospital medicine from patients and clinicians. We're also using health administrative data to determine what the most expensive and costly conditions in hospital care are, and information from both these studies will help target our research, such as clinical trials. And the first trial that we conducted in PERN was a CIHR-funded multi-center trial that addressed how we use technology, so pulse oximetry, in the supportive care of infants hospitalized with bronchiolitis, one of the most common and cumulatively expensive conditions in all of pediatric hospital care. And this often happens in hospital practice. We rapidly adopt technology without evidence, then years later we wonder, does it make a difference, or even does it cause harm? So this pragmatic trial was just published this month in March, and it was led by our Sick Kids group here. So myself, Dr. Patricia Parkin, Suzanne Shu, Karen Breeden-Reed from nursing, Doctors Andy Willen and Mila Moretti, and it included 6 Ontario hospitals, notably 3 community hospitals. And I think that the inclusion of community hospitals is critical for outcomes research for common conditions like bronchiolitis, where this is the place where they most commonly receive care. So why do we do this trial? So the American Academy and Canadian Pediatric Society guidelines recommend using the pulse oximeter intermittently versus continuously, although this recommendation has the weakest evidence base. And experts, largely based on case series, propose that the use of intermittent monitoring reduces the detection of false positive desaturations and unnecessary oxygen use, that it reduces unnecessary tests and reduces unnecessary prolongation of length of stay, and shutting off the monitor reduces alarm fatigue and nudges parents and clinicians to focus on the child and not the monitor. On the other hand, we're going to compromise patient safety by not recognizing deterioration early enough. And there's lots of practice variation around pulse oximetry monitoring. So that graph I showed before was actually around pulse oximetry use in US hospitals. Actually, this study did include sick kids, and it shows substantial variation in the use of continuous pulse oximetry. So you can see on the y-axis is the percentage of patients that are on pulse continuous monitoring while being in room air, and this varies from about 5% to about 95%. And this is after adjustment for patient characteristics. So what did we do in our trial? So our trial randomized infants 1 to 24 months who were stable on the unit for at least 6 hours who could be on oxygen but less than 2 liters into 2 arms. So either intermittent monitoring every 4 hours or continuous monitoring. We used a 90% oxygen saturation target to guide clinical management, such as discharge home. So what did we find? So we found that the median length of stay from randomization to discharge was similar between the intermittent and continuous group, and that the difference was only 2.2 hours, and that it excluded our a priori clinically important difference of 12 hours. We also found that there was no differences in secondary outcomes of medical interventions, such as frequencies of tests and treatments, such as oxygen supplementation. We found that there were similar safety outcomes, so ICU transfer. Nursing satisfaction was greater with intermittent monitoring, and there were similar outcomes. So parent anxiety was not increased with intermittent monitoring, and work days missed up to 15 days after discharge was similar. So based on our results, we argued that hospitals and clinicians should routinely adopt intermittent monitoring. Continuous monitoring doesn't add value, as outcomes such as length of stay, safety, and parent-reported outcomes are similar. Furthermore, when you consider other factors, they also favor less intense monitoring, such as lower nursing workload, reducing alarm fatigue, the fact that recovering infants often experience transient desaturations. Also, shutting off the monitor is aligned with the hospital to home transition, and it also simplifies care. We're not finished yet. This first study addressed clinical outcomes. Dr. Milo Moretti is leading cost effectiveness analysis comparing the two interventions. And Dr. Briyama in our division is leading a qualitative study across sites to understand the barriers and facilitators to de-implementing continuous monitoring and implementing intermittent monitoring. We need both types of evidence, both from the clinical effectiveness part and from implementation science, to really change these entrenched practices. The NIH and many others have really advocated for combining effectiveness studies with implementation studies on how to change practice in order to reduce the time from evidence to practice, the so-called hybrid effectiveness implementation designs. So we have a long way to go in hospital medicine, but we're really excited that we're positioning ourselves to conduct real-world comparative effectiveness studies across Canada. So I remember my professors, in particular Brian Haynes, in grad school at McMaster University, always emphasized that clinical expertise and personalized clinical decision-making is much more than knowing the research evidence, such as from comparative effectiveness research. It also must consider the patient's clinical state and incorporate patient preferences and values. And humility is important to understand the patient's perspective and see them as central to our goal in making good decisions. So the next domain of outcomes research is the patient perspective, which really aims to generate knowledge to align healthcare decisions with patient preferences and goals. And a significant part of hospital medicine in 2021 is complex care, the management of children with medical complexity. This recent CIHI report showed that this population of children account for over 50% of hospital days and hospital care costs. And feeding through a gastrostomy or a G-tube is a common intervention in this population, especially for those with neurologic impairment. So prospective before and after observational studies, such as the one we conducted, have shown that G-tube feeding increases nutritional status, makes caregiving easier, and that parents feel that it has a positive impact on their child's quality of life. Few studies have assessed parental perception of child quality of life, and we found that there was no improvement 12 months after the intervention. Systematic reviews have similarly found benefits of G-tube feeding on nutrition, ease of caregiving, and caregiver quality of life, and there still is uncertainty on its impact on quality of life and survival. So despite these benefits, often conversations with families around this intervention can be really difficult. Parents and family members often experience decisional conflict, uncertainty about which course of action to take when choice among competing actions involve risk, loss, regret, or challenge to personal life values. So what was the core of the distress around these interventions? So we conducted a systematic review of qualitative studies, what's called a meta-synthesis, to understanding the decision-making experiences, values, and preferences of parents children with neurologic impairment. And qualitative methods, I think, are really important to really get at beliefs and values. So we found that the decision-making process was filled with decisional conflict, and this decisional conflict could be understood through three main concepts: context, values, and process. So context referred to the circumstances of the child, parent, and family, and process referred to the information sharing and support that was provided by the healthcare system. But the main theme that explained the decisional conflict of parents was the struggle over the value associated with oral feeding versus G-tube feeding. So feeding by mouth for parents was much more than a means to increasing weight. It meant enjoyment, normality, nurturing and bonding, and feeding as a social process. And tube feeding meant disability and feeding as a struggle. And there's often this disconnect with healthcare providers who are seeing this intervention from a biomedical perspective, nutrition, weight, and parents are seeing this intervention from a social process. Research from anthropology tells us that food and eating has so much more meaning than weight. It's related to relationships with others. It's connected with religion and faith, with development of identities based on ethnicity, race, and class. So when faced with a family who's experiencing decisional conflict, this framework, so exploring the family context, their values, and gaps in the process of decision-making can be helpful in reducing their conflict and help make them make a good decision. So Dr. Catherine Nelson from PACT conducted another systematic review of qualitative studies, which emphasizes the point that parents see value in this intervention in different ways. What one parent sees as a benefit, such as reduced feeding times, may not be seen as a benefit by another parent. And Dr. Nelson makes suggestions around the specific topics, so child topics, parent topics, and family topics that are important to have in these decision-making conversations. So our model has been incorporated in the American Academy of Pediatrics framework to promote shared decision-making when considering tube feeding in children and youth with disabilities. We then worked with the Canadian Pediatric Society to publish guidelines on using this framework to aid clinicians. And this work has also directly informed our approach in the Sick Kids G-tube feeding program in our decision support clinic, which is run by our nurse practitioners, Silvana Appadiciano, Amanda Lee, and also by Julie Johnstone and myself. So informed by the findings of our research, Silvana actually created a decision support YouTube video to help families in the process, which has received over 150,000 views on YouTube since being posted in 2017. It's also one of the top viewed videos on the About Kids website. And then finally, Dr. Nelson showed that with our decision support consultation model in our clinic at Sick Kids, decisional conflict is high pre-consultation, but actually is very low post-consultation with our model, probably telling us that the use of a decision made probably won't have any additional benefit using our model. So then finally, moving to health system performance. So I think humility is really important to recognize that we're just one part of the system. We need the help and the partnership of a system that needs to work for everyone and together. Systems performance research answers whether we're optimally implementing strategies to prevent, diagnose, and treat disease, eliminating waste and ensuring equity, achieving optimal return on healthcare investments as well. And to illustrate this example, I'll discuss my work on tonsillectomy. So in Ontario, tonsillectomy is the second most common surgery performed in children, with over 14,000 performed per year, and it's the 8th most expensive condition in pediatric hospital care. Many people consider this surgery routine and simple. So if it's that routine and simple, we should be doing an amazing job at it. But over the years, there's been lots of concern around the quality of care around the surgery. For example, this seminal paper by Wenberg and Gittleson in Science in 1970 showed that depending on where you lived in Vermont, your chances of getting a tonsillectomy after adjusting for patient characteristics was about 10-fold different, raising the concern around the appropriateness of the indication in certain areas. So as part of my work in the US Hospital Medicine Research Network, PRIZE, we partnered with the CEOs of children's hospitals who funded us to examine how children's hospitals were performing around some key, highly prevalent and cumulatively expensive conditions. So pneumonia, DKA, appendicitis, and tonsillectomy, which I led. And we use this amazing resource, the FIS database, it's amazing both for QI and for research. It contains data from 50 US children's hospitals, including hospitals like CHOP, Boston Children's, Cincinnati Children's, and it contains health administrative data, but also billing data on imaging, labs, pharmacy, room charges, clinical services, and costs. So the first study that we conducted was really to set out to determine the quality of perioperative tonsillectomy care in these US children's hospitals. So we studied 36 US children's hospitals, about 140,000 children who were undergoing same-day tonsillectomy. And we discovered that there was substantial variation in evidence-based process measures. So hospitals should be using dexamethasone, a steroid on the day of surgery, where there's lots of trials that have shown that it reduces nausea and vomiting, and they should not be administering antibiotics. Trials have shown they're not effective in improving outcomes, and they're not good for antibiotic stewardship. So this y-axis shows hospitals, and each horizontal line shows the percentage of children at each hospital from 0 to 100 who receive the right care. So yes to dexamethasone and no to antibiotics. And you can see that variation in the evidence-based process measures range from about 5% to about 90% across these hospitals. And the major factor driving whether a child was receiving the right care was the hospital they went to. So what about outcomes? So again, there was substantial variation in outcomes as measured by revisits back to hospital for complications. So this graph on the y-axis plots the adjusted probability of a revisit from 0 to 14%. The x-axis has the reasons for coming back for complications. So any reason, bleeding or vomiting and dehydration. So for example, if you were a child and you went to a low-performing or high-performing hospital, the probability of coming back for any reason, each of these blue dots is a hospital, would be around 4%. If you went to a low-performing hospital, your probability of coming back would be about threefold higher, about 12%. Remember, these are all same-day surgery. These are otherwise healthy children, no children with medical complexity at large children's hospitals with adjustment for patient characteristics. So lots of variation in processes and outcomes. And then what about costs? So then we studied 28 of the US children's hospitals, about 130,000 children who underwent same-day tonsillectomy. And we found that there was substantial variation in standardized costs. So we used the same unit price. So a CBC at hospital A was the same price as a CBC at hospital X. And the costs varied about fourfold. So if you're a child and you went to a low-cost hospital, it'd be about $1,000. If you went to a high-cost hospital, it'd be around $4,000. And the major source of variation in terms of the resources used were the surgical supplies and also the length of stay. So how long children were staying in the recovery period. And then we also showed that hospitals that used more resources to perform tonsillectomy did not have better outcomes as measured by lower revisits for complications. This suggests that in the healthcare system, we really need to learn from these low-cost hospitals that are able to achieve excellent outcomes. So then what can be done to improve outcomes? So next, we then looked at the impact of national guidelines on outcomes using an observational interrupted time series analysis. So again, we studied 29 US children's hospitals, about 120,000 children, both in a pre-guideline and post-guideline period. And we found that the national guidelines were associated with a modest improvement in the increase in dexamethasone use. So as you can recall, I said dexamethasone is good. So we saw an associated improvement from about 70 to 80% in the post-guideline period. There was a more dramatic reduction in antibiotic use, again, which is a good thing. Guidelines were associated with a drop from about 30% to about 15%. Surprisingly, we actually found that the outcome of revisits actually went up associated with the guidelines. And we speculate that this was related to a major change in practice over the study period. Codeine was black box because of safety and concerns for death after tonsillectomy, and hospitals may not have shifted to effective pain management strategies yet. So overall, guidelines had some impact, but were not enough. What about major system-wide interventions to address quality of care? So in 2014, the Ontario government introduced a health system payment and quality improvement program targeting tonsillectomy, as not surprisingly, we too have high rates of revisits here in Ontario and lots of variation across hospitals. So this system-wide intervention had two major components. First was moving funding from global budgets from hospitals to episode payment. So what that meant was no matter what the resources the hospitals used, whether they used fancy surgical equipment or kept children overnight, they get paid the same amount. And the second component was a quality improvement program, which consisted of dissemination of a care pathway. So the Provincial Council of Maternal and Child Health convened an expert panel of ENT surgeons, pediatricians, respirologists, and anesthetists to create Ontario-specific guidelines. And this panel included Dr. Indra Narang, Dr. Evan Props, and myself as well. And then recently, Dr. Astrid Gutman and I conducted an observational study using an interrupted time series analysis using ICS population-based data to ask the questions, did this system-wide intervention make any difference? And there have been really very few child health funding and quality improvement system-wide interventions that have been rolled out, never mind that have been evaluated. So we studied 111,000 children, and there's actually 86 hospitals in the province that perform pediatric tonsillectomy. And we looked at a period before the system-wide intervention and a 5-year period afterwards. And overall, we found that there was improvement in quality of care as measured by trends in revisits for complications. So first, if you look at all-cause revisits, there was a rising trend before the system-wide intervention, which was then halted. If you look at dehydration or feeding issues, which is directly related to the use of dexamethasone, this was on the rise before the system-wide intervention and then gradually reduced, which was a good thing. In terms of pain revisits, similar to the US, there was a rise in pain revisits before the system-wide intervention, and then this was halted afterwards. Surprisingly, we actually found that there was a step-level increase in bleeding revisits. We're not sure why. The guidelines did not specify a new surgical technique, so this requires some further investigation to understand why that occurred. The other outcomes we looked at were opioids. So reducing opioid use is an important patient safety target. And you can see here codeine use before the intervention was already falling, largely because of Health Canada and FDA warnings. After the intervention, it continued to drop. In terms of non-codeine opioids, such as morphine, this was on the rise before the intervention. And you can see post-intervention was associated with a gradual decline. We looked at inpatient tonsillectomy, so the use of admission for tonsillectomy as a balancing measure. This was on the rise before the intervention and was halted by, or it was associated with a halting with the intervention. So this system-wide intervention was associated with some improvements of quality of care. It wasn't perfect, and perhaps if the payment was linked with outcomes, there would have been better, and if there was better hospital implementation, we would have seen better outcomes. But this study does provide some evidence and some guidance around other health systems that want to improve tonsillectomy care, and in fact, probably can learn from the Ontario experience to refine and hopefully achieve better outcomes. So then to summarize, outcomes research is one framework for the scientific investigation that's needed to understand what's being achieved for patients and what can be done better. Humility is also important, I believe, for recognizing the limits of science, the importance of the patient perspective, and that we're only one part of the system. I think that these realizations can drive us to make things better through science and through improvement. And then lastly, for the future. So I believe it is an exciting time to be a generalist, a hospitalist. It's a young field. It's one of the fastest growing areas of practice in North America. So what are some opportunities and challenges in pediatric hospital medicine? There are a lot, and I'll just comment on a couple. So the first, and this may seem odd that I'm saying this, I think in order to truly improve outcomes in hospital medicine, we need to work and partner outside the inpatient unit. So upstream and downstream from the unit and across sectors to really make a difference. For example, health equity and social determinants of health probably have the biggest impact on outcomes in hospital medicine. So we need to prioritize, test, and discover how we can use this lens to improve outcomes with experts within and outside of this biomedical enterprise that we work in. And then mental health. So just as the new models of care emerge for managing children with medical complexity, we need models of care for managing the rising trend in mental health disorders seen in hospital medicine. Second, the success of research networks such as PERN, I think, are going to be critical for our field. Can we get to where other fields like oncology and the emerge are in terms of research networks? I think also are important are quality improvement or safety collaboratives like the one Dr. Coffey leads, Solutions for Patient Safety. And third is data infrastructure. I think this is going to be critical for us, not just for research, but also for learning in QI. Will we be able to harness data systems like EPIC to learn, test, and improve? And fourth, what about Sick Kids Strategic Plan for Precision Child Health? Will Precision Child Health lead to unprecedented outcomes in hospital medicine? Last week, we heard from Dr. Lewis about the opportunity around precision therapeutics. Will we soon see the day where AI improves bronchiolitis care by early and accurate prediction of deterioration on the inpatient unit? Will AI and genomics actually identify a subgroup of infants with bronchiolitis who actually benefit from steroids and bronchodilators? Will genomics elucidate the basis for complex feeding disorders, enabling new therapies, preventing feeding tube placement in the first place? So I think the future is exciting in hospital medicine. So I'll just end off, just to summarize. So today I shared my journey, which was inspired by a generalist approach, practicing on the inpatient unit, this fundamental question of how we can do better. A question that I think is central to our field of hospital medicine. I think to do better, we really need to be focused on our pursuit to being better clinicians and also to generate scientific knowledge to improve care and outcomes. And I think central to this is humility, something I think that we've really been forced to understand through this pandemic. And humility, again, it's a strength, it's a rich multidimensional construct. It's critical for us to doing better at the bedside and for opening our minds to how we can improve. And I think whether that's through clinical practice, research, or quality improvement. And I think no matter what the approach is, whether it's outcomes research and evidence-based medicine or AI and genomics, I think in order to maintain our moral compass, we really need to foster an environment that nurtures humility in the way we see our own limits, our position, and also the care for the patients we serve. An ounce of humility, I think, is worth more than a ton of arrogance. So I wanted to thank my colleagues, my family, and my colleagues in pediatric medicine, the G-tube feeding program, my lab in the Research Institute, and all the children and family that I've looked after over the years. Thank you.
Thank you, Sanjay, for that really amazing and inspiring grand rounds, and for talking about the future as well and your expectations and predictions. So we have some questions. First from Dr. Simon Ling. He thanks you for a really fantastic presentation and says, as humility and intrinsic motivation seem so important for excellence in clinical care, can we teach them? And if yes, how?
Yeah, thanks. Yeah, thanks, Simon. That's, I think, an excellent question. And I've thought about it a lot. I mean, humility is an interesting one. I think that, you know, how we develop humility probably goes back to childhood. But I also think for intrinsic motivation and humility, there's a huge role leadership can play on different levels. So I think in terms of how we foster our environment, the messages that come from the institution, from leadership, but also on the ground, you think about when we're working with trainees about how we talk about what we enjoy doing, what's important, and even being vulnerable and talking about, you know, mistakes and talking out loud and how we deal with patients. I think role modeling is critical in emphasizing the importance of both humility and intrinsic motivation for what we do.
Thanks. That's great. The next question is from Dr. Zia Milla, and she asks, what are your thoughts about potential fellowship training in PHM, I assume pediatric hospital medicine?
Yeah, no, I think that's a great question. So in the US, just for people that are not familiar, they've actually gone to board certification. So it's actually to practice as a hospital medicine practitioner, you need to do a fellowship, and it's ABP board certified. So we've had this discussion in Canada, and I think there probably are a lot of advantages of fellowship training in pediatric hospital medicine in terms of advancing the field. I think one thing that I know not everyone would agree with, but I think unlike the US, I think it's really important that we stick together as generalists. There's a lot of benefit in terms of scholarly capacity and mentorship. In the US, a lot of centers have divided into hospital medicine and outpatient general pediatrics. I think there's a lot we gain in terms of thinking across the inpatient unit and across sectors.
Great. Theo Moraes has a question. Great talk. Can you comment on the challenges you may have faced establishing hospitalist networks?
Yeah, so that's a great question, Theo. I think the first thing, I think timing is always important. I think in our field, from a research capacity, there aren't a huge number of people that are research trained in our field. Not to sound arrogant, but there's probably more people here at our institution than at most institutions across Canada. So I think one of them is training. The other one is time. So I think we all know that to be excellent at research, you need time to do that. And traditionally, the way generalist divisions were funded and staffed, it was largely to do clinical work and teaching. I think the third thing is leadership. So leadership from agencies like CIHR to department chairs to really understand the value of a generalist approach in a multitude of areas within academic medicine. So I think that, over the years, I think some of the people that were before me, like Bill Feldman and others, sort of set the stage. They kind of made it easier for us to actually accomplish what we have today.
Great, thank you. Jeremy Friedman says, brilliant talk, really enjoyed it. Any comments on how to realign our structure in academic medicine, which, as you point out, tends to reward individual achievement and perhaps less recognition of internal motivation and humility?
Right. Yeah, it's interesting because like this year in January, I was doing my RI appointment, and it really made me think about these processes that where you really need to position you as the person. I think like in hospital medicine, it's team science. Like, and all this stuff, where my name goes and what our contributions are. Unfortunately, whether it's ironic that I'm talking about humility on the day I'm giving professorial rounds, because that whole application is around what I've done, and similarly in the research institute. So, there's probably definitely a role for that. And I know why institutions need to put some focus on individual accountability, totally get it. But maybe there's a balance that we can achieve that promotes team-based work and moving forward together as opposed to individuals. And it's a complex issue. Just some initial thoughts on it.
I think it's great. Maybe you can help us figure out that dilemma, because I think it is a big challenge. Maybe for a last question, there are many, but from James Anderson, you spoke about the role of patient and family values and preferences in relation to decisional conflict and communication. Can you comment on the role patient and family values and preferences play in shaping research itself, essentially patient-oriented research,
right.
Your research specifically?
So I think that's important, and I had alluded to it, but within our research network, PERN, Dr. Peter Gill is leading a CIHR-funded study. And unlike a lot of research networks, we're starting by saying, what are the priorities of patients in terms of where we should even focus on? So I think we're trying to set that stage. We're just learning on how to do this well. I think everyone is. So, I think in terms of the actual network, we're thinking about having organizationally parent partners embedded within the network, but also thinking about it from project to project. So I think it's going to be critical, especially for the space that we're in, where we're really trying to inform bedside care. I think that part's going to be critical, but we're just learning on how to do this well. I think, we're hopefully we'll get it right over the years.
So I really want to thank you again for an inspiring talk. Hopefully many trainees. There's almost 200 participants, one of the highest numbers I've seen, even for a non-COVID talk in this whole year. So I think you really resonated with a lot of people. And I think social media is very active with lots more compliments for you, Sanjay. So congratulations on being a great individual and team player and showing us how it's done. Thank you.
Thank you so much. Thanks.
Thanks. Have a great day, everybody.
Bye.
Okay, bye.